welcome everyone. I'm Marguerite, Director of Tech for HIV, and today we're thrilled to bring you our panel, The Role of Artificial Intelligence and Other Technologies in Public Health. For those of you watching who are new to Tech for HIV, we are the alliance of tech companies and public health institutions working to scale existing and emerging technology for greater impact in HIV. Tech for HIV strives to increase healthcare access, improve treatments, and lower costs through coordinated and systemic partnerships, effectively bringing public health into the 21st century. You can learn more about our work at techforhiv.org and stay up to date on events by following us on Twitter, Instagram, YouTube, and Facebook. We're joined today by a diverse lineup of panelists, each dedicated to bridging the gap between technology and healthcare, as well as David Milestone, who will moderate the discussion. Dave is a senior advisor to McKinsey & Company's social sector and global public health practices. Most recently, Dave led USAID's Center for Accelerating Innovation and Impact, which applies business-minded approaches to the development, financing, and scale-up of health innovations. Dave, over to you.
Thanks so much, Marguerite, and I'm excited for this discussion today. I think as all of us will agree, there's a ton of potential with AI in public health, and its impact can be transformative, but we also know it faces many challenges in its application in appropriate and fair ways at scale. So to set the stage for the discussion, I wanted to walk us through some findings from a recent report that we did in my time at USAID, along with the Rockefeller Foundation, the Gates Foundation, and the Boston Consulting Group, that really tried to take a step back and take a look at where we were with AI in global health, but more importantly, what we could do together to move it forward more quickly. What I have here on the screen is a look at sort of a more illustrative look at sort of past technology and its development and growth over time. I think what we would all agree is that oftentimes the global health community are often late adopters of new technologies, from when the internet came online to mobile technologies back in the early 80s to blockchain recently and AI. The global health community, I think we can agree, can do a much better job of being earlier adopters of new technology. We also wanted to take stock of and frame out where the potential of AI played across an entire health system. And so we tried to create some frameworks around how we could think about different categories of the use of AI in global health. So we developed this framework that's gotten sort of a lot of use and was even featured in the Lancet, but I think it does a nice job of sort of at least structuring some of where the opportunities lie, from population health that we've seen a lot of application of AI in this recent pandemic, to what we hear a lot of and focus a lot of our attention on, sort of individual health, from sort of care routing to care services, from behavior change to diagnoses, to image-based diagnoses, to, of course, clinical decision support at all levels of the health system. And then things like health records and support and potential in the pharma and med tech world, specifically around clinical trial support. But we also know there are a ton of challenges, none of which are necessarily unique to any given use case. From data availability and quality to making sure these business models are sustainable, especially when we're working in low middle income countries, to privacy, ethics, and data ownership, which I know all of our panelists will have some important thoughts on, all the way through to things like evidence. Where is the evidence that can link specific AI use cases and technologies to health outcomes? In the public health world, we're really driven by data. And so I think we need to do a much better job of bringing that data together around the potential of AI. We also sort of looked at framing out where there were potential opportunities for us as a global health community to work together to accelerate the appropriate use of AI. From funding specific innovators, we'll talk about this a little later, but a part of our study, we looked and did an initial scan and found over 300 startups, health-related AI startups, primarily which were focused on high-income countries and high-income settings. And so how can we support innovators with new innovative financing mechanisms, for example, that might incent them to make sure that their technologies are relevant in low middle income countries, to supplying them with technical assistance. Then this ROI and evidence base, how can we work together to make sure that we're capturing the right data? And then using data, that will be a big topic of conversation today, how that data is interoperable. And then of course, investing in human capital. So how do we build capacity in low middle income countries, ministries of health, for example, to make sure that they're able to both assess what promising AI technology is, but more importantly, implement it in safe and effective ways. And then of course, the seventh area is this idea of coordination. How can we work together to bring this to scale? So with that, that will lay the foundation for our discussion. And so I will start the panel by opening it up with a very broad question to everybody, and please raise your hand or just chime in. What are you all seeing as the highest potential in AI and public health? And what are some of the most promising use cases you have all seen in your respective work?
I can start. Hi, my name is Leo Jans, and I work in the AI leadership at Change Healthcare. And I have had experiences on managing data and processing, just in 1 month, about 250 million records of data in order to find diagnoses. And I think, on a broader scale, that the data, in the private sector around, social networks and ads and pardon me, all that, there's plenty of data, so you can actually do a lot more with it. Now, in telehealth and in other areas, the access to patient data to actually create meaningful predictions is not there yet. So once you have access to data, you can predict things that can help patients, you can predict things that can help providers to shorten the time it will take to collect information from patients. So, today a provider spends 40% of his or her time to actually do data entry, data collection. And if we can reduce that, we can actually free up providers to do what they're actually taught to do, which is to improve people's health. And I think that's one area where there's an opportunity to improve.
Well, thanks so much. And Leo, I kind of jumped the gun because I wanted to get right into the content, but and so maybe we'll start with you. I think it's important to introduce the panelists. So Leo, why don't you give us a brief introduction of yourself and your background?
Yeah, I'm, as I tell my daughters, I buy pizza for software engineers. So I'm an engineering manager that has worked in healthcare for some time now. I was the VP of engineering at Apixio, which is a great company that is processing data, healthcare records to gain insights for improving patients' health. And was in charge of the pipeline there that actually processed these, close to 250 million of healthcare records just in a month alone. So, and currently I've joined Change Healthcare as a part of their AI leadership to deliver different, on a broader scale, improvements to both to claims management and to other areas for both plans, such as doctors, your local dentists, and the providers.
Great, thanks, Leo. And you win already for the most impressive microphone of the panel. Bill, I'm just going to go around my screen here. So, Bill, great to meet you.
Hi, everyone. Thanks so much for inviting me. I'm Bill Kassler. I work as IBM Watson Health's Chief Medical Officer for Government Health and Human Services. But I got my start as an HIV clinician, doing a fellowship at UCSF in San Francisco. I joined CDC and spent quite a number of years in the HIV prevention group at CDC. I ran a state health department and ended up being a founding member of the population health group at CMS's Innovation Center before coming over to IBM. And I lead our population health efforts, and post-COVID, our public health efforts, applying AI and a number of other technologies to improve public health.
That's great, Bill. Great to meet you, and thanks for being here. Cynthia, you're next on my screen.
Well, hi, I'm Cynthia Weber. I'm at the University of Sussex in England. Thank you all very much for the invitation. I too covet Leo's microphone. That was the first thing I saw. I want that microphone. I started becoming involved in these AI conversations when the Stanford University study was released that claimed that facial recognition technology that was powered by AI algorithms could better predict a person's sexuality than the naked eye. The bundle of claims in that sentence is extraordinary and provocative, and doesn't bear out whether we're talking about technology or just how one understands orientation. So that led me to a series of conversations that I had with Richard Brzezinski at UNAIDS. And through those conversations, Richard and I started working with Jolene Kong, who's on the panel today, on a study of HIV and AIDS risks and benefits in relation to AI and big data technologies. So that's kind of some of the specific work I've been doing over the last few years. What I'm particularly interested in is, as I've seen how these conversations evolve, I'm very interested in how the stories about AI get told. AI and big data. And so that's a kind of emphasis of my interest these days.
That's great. Nice to meet you, Cynthia, and thanks for being here. Sean, let's go to you.
Hi, everybody. My name is Sean Batir, and I am currently an AI principal within a branch of the DoD. And one of my projects that I focus on right now is about how to aggregate information for national defense. So some of the problems that we address are pretty invariant, and they appear both in the defense sector as well as in the public health and health medicine sector. So I'm looking forward to seeing what some of our overlapping insights may be, and can't wait to work together.
Great, thanks so much, Sean. And last but not least, Jolene.
Hi. Hello, everyone. My name is Jolene. I hold a Master of Development Studies from the Graduate Institute of Geneva, and that's when I was doing my master's in Geneva. I did an internship at UNAIDS, and I met Richard Brzezinski and Cynthia, and together we did a research project. Basically, we look at the use of AI and big data in the HIV response in the different stages, such as prevention, diagnosis, and treatment. We conducted case studies on the current tech being used, and we closely look at the risks and benefits of these techs from a very human-centric perspective. So the main lessons we learned from the HIV case is how AI is shifting the human-centric approach to a more machine-centric approach towards the public health. And it is consistently demonstrated during the COVID situation. I'm very glad that I got invited to this panel, and I look forward to having a meaningful discussion with the panelists. Thank you.
Well, so we will jump back into that question that I of course, jumped the gun with. And Jolene, maybe actually send it back to you more specifically to maybe talk about some of the promising AI, big data, HIV technologies, either in development or in use. And what are you thinking are some of the biggest benefits and risks with those?
Sure. We actually look at many applications of AI and digital technology in the HIV and also in the COVID-19 response. So I want to share two examples on prevention of HIV and COVID-19. For prevention of the both pandemics, the use of AI and technologies they are, as I said before, is bringing a machine-centric shift away from human-centric measures. So the two case studies both happened in China. The case study about HIV is about how Baidu, the Chinese biggest search engine, is combining users' search query data with the big data of their living habits and sexual behaviors to predict predict their HIV status and possibly new HIV outbreak. Another case is during the COVID-19. All citizens in China, they enter the public spaces by presenting their AI-generated health codes, either come in the colors of green, yellow, or red, that shows on their mobile apps, which combines with their travel history, big data, to help them maneuver around different places. So both cases, they benefit users and the government for efficiency of track and tracing, and it's also said to be quite accurate. But what we want to look at is the problematic sides, because firstly, there is a severe lack of transparency, as the AI algorithms, they work in a black box. So no public users know exactly how they classify people into different categories. So sometimes people are really bewildered when their health code go from green to yellow and sometimes to red, and it's very difficult to understand what has happened behind the AI algorithms. And secondly, although both tools are so-called for beneficial purposes, the entrepreneurs or the app developers or the government who use these apps, they have uncurbed access to people's personal information, which the entrepreneurs may see them as very important and tradable financial assets. Especially in the HIV case, is very problematic because sex behaviors of people are traced and collected. And in many countries, we know that the key populations of HIV and also people living with HIV they often face stigmatization, discrimination, and sometimes even criminalization in many countries. And such tracing and tracking of personal information is a serious violation to human rights. And we know that anonymity is not solving the problem here, as everything can be de-anonymized. So it creates fear and distrust for people using such health services, and they may refrain from seeking help and going to access for public health services if they are within the group that are stigmatized and criminalized. So I think a very important lesson here to learn is when machines, they analyze humans, they use threads of information to create a dehumanized data double. So it's often preset by existing prejudices and stereotypes. This is not for human and by humans, and of course it's not benefit human as we anticipated. So that's our worries when we study these case studies.
Wow, thanks, Jolene. Really, really interesting. Bill, I'm wondering, with you at IBM, what are some of the things you're most excited about with AI and public health? And have there been any lessons in sort of what's been happening around COVID?
Absolutely. I'll start by a little editorial. I'm a huge advocate of AI and the practical applications for public health use. But it's not only AI. It really needs to be seen as one piece of a puzzle that includes people and skills, good information and data, and the technology and the policies as well. So with that preface, we look at AI holistically in that large infrastructure. I'll focus on 6 basic use cases that we have AI in public health that I think are really exciting. The first is predictive modeling. And in particular, the ability to add social determinants of health and place-based data to reflect and to add that to biomedical data in order to better predict the epidemic. So we saw a startup, Blue Dot, do that early on in the epidemic with travel. We're doing that in HIV with PEPFAR and CDC and Project Hope in Namibia, where we're looking at social data on employment and seasonal migration and social events, and adding them to biomedical surveillance in order to predict and using machine learning in order to predict where the outcome will be so that Namibia can actually close the epidemic and get to that last mile. The second use case is causal inference using real world data. Often we know that randomized trials are not feasible for whatever reason. And using real world data, that data found, for example, in claims or in electronic health record, we can create cohorts and use machine learning to substitute for traditional statistics. And we've done that in COVID with a COVID a cohort that we've developed through our EHR data, and looking at people who have received, let's say, drug A versus drug B and have a chronic condition, and are getting some insights that I think machine learning can provide that classic statistics can't. The third is population segmentation, the ability to take data and stratify subpopulations based upon very precise traits, social determinants, behavioral, geographic preferences, and to then be able to target in a precision way folks with messages or interventions that are very much tailored to their needs, to their information needs, and to their social needs. The third is the use of natural language processing in order to get situational awareness. So in the Namibia example, we are scraping news in order to find out where there are risky social gatherings for HIV. You can look at, in our cohort for COVID, before there were codes for COVID and before doctors in the EHRs put standardized ways of coding for COVID. They wrote things in notes that gave early signals for COVID. So by using NLP, we were able to work with CDC and to create a COVID and respiratory disease cohort early on before, and that early signal has been very helpful. The fifth is automation. So the use of chatbots is one way in which we can automate. And some of our clients, public health departments, social service agencies, and hospitals were overwhelmed with the surge of people calling and asking for information. So we could triage the people who needed a human quickly, and for those that just had questions that they could answer through the chatbot, that really helped efficiency. And then the last one is individual empowerment. Again, by learning about individuals, by bringing lots of data together, we can then help individuals make the right lifestyle choices. And an example of that would be work that we're doing with Medtronic around a personal diabetes advisor. Medtronic has a patch that sips every 5 minutes the blood sugar, and they're using that to drive an insulin pump. But what do you do with all that excess information, near 24/7 blood sugar? Well, we use machine learning, and we're able to then link that to diet and exercise, and then render that information in an app to somebody, so that when they go into a restaurant and they decide that they want to have a meal, that app can tell them, well, the last time you did this, here's what happened to your blood sugar. As a matter of fact, the last 5 times you did it, so maybe you should consider not having the fries, or maybe you should adjust your insulin. And then we also found that we could predict a hypoglycemic event 4 hours before that event happened. And that is very, very helpful for kids. Parents who put their kids to bed and then have to wake them up in the middle of the night just to see how they're doing, and having that peace of mind. And so I know that's a lot, but those are the 6 basic public health use cases that excite me.
No, that's great, and gets me a little inspired by all the work that's actually already happening with AI. Cynthia, something you said in your opening and in your bio really jumped out to me. This idea about learning and understanding the stories that are being told about AI and big tech. how these stories are told, and what the telling of these stories does practically, politically, and ethically. I think that's so relevant now because AI in many ways is a brand in and of itself, and not everyone has a good understanding of what the potential and what the potential risks are. So I'd love to hear your perspective and what you're learning there.
Thanks. I'm learning lots already in this conversation, so thanks very much. Everything everyone said is very interesting. I actually would say that the brand at the moment is AI for good, and I think that that's a brand that a lot of people are around. As far as I understand it, it has its origins in the UN International Telecommunications Union AI for Good global summits. And it's really become the kind of dominant brand that's overtaken all of the other narratives around AI, in part because of the breakout branches, one of which is AI for Health, which is done in coordination with the World Health Organization. But I think that if we unpack that and unpick that and try to think about who free rides on that and who doesn't and in what ways, one of the things that really interests me, and actually this was an issue that Bill flagged in one of the earlier emails to all of us in the group, is about the connection between policy, at the policy level. And what's really interesting to me is how different kinds of stakeholders are making different kinds of claims and putting forward different kinds of narratives about AI in order to make enormous claims about solving what have long been intractable national and international policy problems. So, for example, AI for Good can achieve the Sustainable Development Goals of the UN, or they can help. Or the report, Dave, that you were a part of for USAID on, how can AI for Health happen within a sustainable development framework and bring public health or improve public health in lower and middle income countries. So I think that there are at least three narratives that are actually occurring here rather than just the one. I think that the hope narrative, I call them hope, fear, and freedom. So the hope narrative is the AI for Good narrative. It basically says, look, we all are well-intentioned moral actors, and we want to use AI in order to help humanity. So that seems to be a framework in which we'd all love to see ourselves. Accompanying that, or sometimes coming up against that, is what I call a fear narrative, which is the worry that AI actually can harm humans. And some of that's very unintentional, and some of that needs to be cleaned up, and some of that, we think we'll get to a better place sometime. But really how this narrative works is to basically say, when I use AI, it's for good. When my competitors use AI, it could be for evil. And so you see this in kind of the back and forth between, for example, the United States and Canada about their AI national strategies. Mine is good, but yours is evil. And then the third one is what I call the freedom narrative. And I think that this one is about trying to harness AI in order to achieve more freedom for humanity. And so this is a sort of an emancipatory story about AI's emancipatory potential to achieve freedom through technological innovation. In a COVID-19 context, that might mean that we have fewer national lockdowns because of AI and big data technologies, and now we're down to local or even household level or individual kinds of lockdowns. But I think that all of these stories coalesce around this sort of grand narrative of AI for Good, and I think they all depend on, or often depend on, I shouldn't overgeneralize, on three kind of rhetorical strategies. Sorry, I'm an academic. Academics think in threes, so I apologize in advance. But these three rhetorical strategies I have to do with the future, the personal, and the pure. And if we think about them in a public health context, the future is always about talking about or having a conversation dominated about this idea that AI and machine learning can revolutionize public health. whether one comes at it from hope, fear, or freedom, that's the conversation. So it's this future-oriented promise or potential. The personal narrative is to try to sort of say, well, look, we know AI technology is boring calculations and data scrubbing and, you know, painstaking data entry, the things that Leo was talking about earlier. But actually, if we can think about the personal moment is to invest AI with this kind of ability to think and feel for us as an audience about that.
No, Cynthia, I think that that is so interesting, and I could spend the entire day talking about this. AI is so nebulous, especially oftentimes to policymakers. And so how we communicate both, as you said, the hope and the fear is really important and can affect how we move forward. But you mentioned Sean and sort of his work in the defense space. I think it's really interesting, Sean, to hear your perspective on what are you learning there, and what do you think is relevant from what you're seeing there to the health space. And then I will open up a few broader questions to the group after that. Sean.
Yes, yeah, thank you for that. And Cynthia, I really love your breakdown of these three narratives of hope, fear, and freedom. That was a really nice paradigm to sort of interpret this through. Yes, so David, to address your question, I have observed that a key problem of our time and, you know, arguably of our generation could potentially be one of information overload. Now, there's sort of a consilience, right, between applications of AI, both in the defense sector where I'm working now, and applications of AI in the public health and bioengineering sector, which is actually part of my history. I used to actually be involved in a PhD program in bioengineering. And prior to that, I was actually also looking at applications of AI in the automotive sector. And across all of these sectors, defense, health, automotive, we see time and time again that the quality of an algorithm developed actually gets heavily dependent on the data that are brought about. And what do I mean by that? Like, what do I mean by the quality of the data? Well, one of the universal issues is when we start trying to tackle larger problems. For example, when Sean Howell and Marguerite were working on the COVID-19 study, we had to aggregate data from multi-tenant sources. And typically the way that people actually store their data tends to be different, right? Like, they might not all be using the same type of database. And even if you are using the same type of database, you might have different fields and values. And so the ground truths that people are recording in different parts of the world or in different parts of the nation, when you try to aggregate that to the same question, because AI is not sentient and doesn't possess this intuition, it's heavily dependent on those initial ground truths that you bring to it. And so in connection with something that Jolene actually said, which is like, this AI approach that we are engaging in is not meant for people, it's meant, like, you know, for this sort of data. You see that as fallout. And so one of the key things that I think are particularly interesting is, one, how do we enforce and how do we regulate sort of like standards and consistency across collaborators, right? I remember, at least in the academic model, when you bring in a collaborator, like, there's always a little bit of latency in terms of like making sure that like your research teams are looking at the same data that are all relevant to each other. And we see this even in the defense sector, right? Like, when you bring on a contractor or something like that, sometimes the way that data is stored is also different. Different agencies may store information in different manners. And having a sort of like universal ability to understand what people define as ground truths, I think, is particularly key to helping us build and move forward with having these types of effective algorithms. And from there, once we can have a common language or common parlance, then we may be able to better address this concept of information overload. Because then if everybody's ground truth, right, is a little bit more synchronized, then the capacity to extract intuitive understanding may be a little bit more realistic than it currently is today. So, part of my response to you, David.
No, really, really interesting. I want to go actually switch gears a little bit and go to Leo, based on something Bill had brought up, and specifically social determinants of health. You know, oftentimes that data hasn't necessarily been included in some of the work that we're doing. Where are you seeing there being opportunities but challenges around social determinants of health today.
Yeah, thanks. Let's start with, we're talking about health, right? So WHO defined health as a complete state of physical, mental, and social wellness. That was done like back in 1948, like 72 years ago. And I see a lot of the conversations around health is all about the physical and the mental piece. But, if you look at, the social part of it, about food insecurity, about social insecurity or loneliness, about housing insecurity, homelessness, all that data is actually present in the health system, in the charts. So we did, I got together with a data scientist and a product manager and said, okay, let's look at a cohort of patients and see what we find. And we came up with our own 3 kind of codes, right? The food insecurity, housing insecurity, and social insecurity. And lo and behold, we found a lot of cases where people coming to the hospital and say they live in a car, and nothing really happens. So there was a person who lived in a car. He had an infectious disease that required regular IV treatment. And he would go to ER on a regular basis to get his IV, to get his treatment. Now, this provider group was able to pair him up with a organization, so he found a place to live. And now he could do the treatment at home. So he had what I call a social comorbidity. He had an infectious disease, and he had housing insecurity. And I think that's back to what Bill was alluding to, was NLP, natural language processing. In this case, we were able to detect the fact that he had spoken to his doctor about living in a car, combined with a population health saying, give me all the patients that have a housing insecurity and this certain condition. Let's reach out to them, and therefore you can not only get a reduced cost of care, but you can also improve people's lives. And I think that's back to tying to Cynthia's thing, why we're here, right? We're, we all want to improve people's lives. That's why I wake up in the morning. And so that's one example, I think, where AI can help us get that data. And when we talked to this customer, they were like, wow, can you give me a list of all the people that have this and this and this and this? So it's kind of frustrating, but also a great opportunity to know that the data is present in the electronic healthcare records. Now we just have to go and find it and actually make useful use of it.
I'm wondering if I could jump in and add some more color to that.
Sure.
So I think there are a number of data and technical challenges for public health and clinicians to leverage and operationalize social determinants. I think the first is that we're very confused about the term, and we often use that term both for individual level data as well as population level data. And they're very different and very different use cases. And so a part of what we in technology need to do is to help users figure out what the data they need to collect for the data, for the problems that they need to solve in the right analysis. And that's even before we apply AI models. I think there are challenges with data collection. Particularly, it's really manual, and you have to almost ask everybody through a survey or a clinician in order to get that information. And I think AI can really, really help. Again, and in deference to Cynthia, this is formative with demonstrations, but not commercial yet. By reading notes in the electronic health record and being able to get dynamic views through social histories of an individual's social needs. I think the second thing is that AI, and in particular deep learning, is very, very well suited to bring insights from multimodal data sets. And so you can have deep learning models for different types, and then you can have models on models. And so we really haven't yet begun to combine all of these various different data sets, the social, the behavioral, the economic, the clinical, the biologic, and really exploit that. But I think we're on the verge of doing it, and I'm really hoping that data scientists and folks in AI research invest in this area, because I think it's really promising.
Thanks both. I think a related question that begs to ask is around sort of ethical concerns in the use of AI, specifically in public health, specifically in marginalized populations and low resource settings. Maybe Jolene, you sort of touched on this in your opening comments, but maybe you can talk a little bit or start out the conversation around what are you seeing as some of the big ethical concerns, but more importantly, what do we need to be doing proactively to help mitigate those?
Yes, sure. Firstly, I would like to add on to Leo and Will's comments. So I noticed that they often talk about data collection and what we can do with all the data collected, and we can make use of them into improving people's health. But over here, I would like to emphasize when we talk about data collection, we need to be more specific about which data collector we're talking about, because the stakeholders in this case is I'm very concerned with the stakeholders who is collecting the data. So whether it's government, or is it the big enterprises who are developing applications or softwares, or the scientists just purely for research, or the entrepreneurs who are having a startup company that want to collect data and bring us a product on healthcare. This is very important because during a AI for Health conference that I attended in Geneva, I heard, I've listened to a lot of discussions on how big companies and how different stakeholders are going to make use of the data collected to bring a better healthcare service for people. But there's one entrepreneur who really caught my attention when he said, when he bluntly said that data of the people they collected is their very important financial asset. So they value this asset because this is what make them rich. So in that sense, we really need to consider who are we talking about in the when we talk about people collecting data, because different people have different purposes of data collection, and it will be put into different uses. And when we talk about improving people's healthcare, we are talking about these people. We are talking about are the users of the healthcare services instead of the other stakeholders. So about the question you asked me on the ethical issues. So there's another example I want to bring out that were presented in our report. So we compared for example, there's one new testing tool for HIV diagnosis, which is it's a new device that can be inserted into your mobile phone, and so that you can put a drop of blood to do the HIV test, and the results are given by the mobile app within 15 minutes. And it's reusable. It's very convenient. You can do it at home or anywhere. So we compared this new tool with the current self-testing toolkit. So that's the thing. It's being promoted by UNAIDS. So these are the offline paper tests. They work by users mailing the samples to a lab and calling a few days later to hear about the automated lab results. While the advantages of the mobile app, the new tool, is very apparent. It's very time effective. But its disadvantages are also quite plentiful. So they are tracking and tracing people's data, there's a possibility of the app developers tracing and tracking people's data uploaded. And when these data of testing results are uploaded into who knows where, so this is very problematic, because mobile app security level is very doubtful in the first place, and in the second place, we start asking ourselves, is it really necessary to having the possibility of sacrifice one's confidentiality for the relative time efficiency that we wanted to achieve for the new mobile app? And we know that the key populations and people living with HIV often face a lot of stigmatization and criminalization threats. And this threat, any threat to their privacy or to their confidentiality, might cause them to rephrase from testing and approaching helps. And once we know that there's this possibility, we need to start thinking, is it really necessary to develop something that's fast and efficient, but on the other hand, it might sacrifice someone's confidentiality and security, and threaten people's confidence to our healthcare services. So that's the ethical concern that Cynthia and I were really care about.
Thanks, Jolene. Sean, I wonder from your perspective in the defense world, I mean, how are you thinking about ethical concerns with AI, and what are their related lessons for the health space?
Yes, yeah. So that's an interesting question, I guess, in terms of understanding how we can frame AI as something ethical. A key language that appears in both the defense sector and also in the public health sector is trust, and particularly how much can you trust the outcomes that are being produced by these recommendation systems or classification methods. And again, a key concern there, or something that's just more of a problem area and focus, is what is the source of that data, right? So can I trust that this conclusion that my algorithm has provided me is coming from verifiable resources, and do we believe in what the ground, like not the ground truth is, but where we got the initial sample from? And then a second step after we validate that level of trust is more of a human perception of the AI, which is, or the ML algorithm really is a more accurate word. There are still some people in both public health and also in the defense sector that just don't believe in these conclusions, like they don't believe in some of the applied statistics, which is surprising to me. And then it just becomes like a strange conversation. But that's again why I like to revert to this topic of how we need to confer common language, or maybe schools should make basic statistics mandatory. Yeah, I think it's. I'm not saying that that's the only way to interpret things. You know, of course, there's context, but at least equipping people with statistical intuition from an early age or an early phase in life can really make these conversations go much more easily.
Yeah.
I wonder sometimes calculus is the terminal degree for math in school, and if it were statistics, how much more numerate we would be as a society around a whole range of issues around risk. I'm wondering if David, if I could make one more point to add to Sean around bias in AI. I think it's huge, and I know I personally and my company is very, very concerned about that. I think particularly when there is transparency is so important when there is oftentimes algorithmic untransparency. And one of the ways to do that is by being transparent in terms of what is the data set and what are the biases in the data set, because every data has bias. And then secondly, who are the people who train them and what are their biases? Third is how it's being used in decision-making. I also think that there may be, and I know some people are going to shudder at this, there may be tech solutions as well in terms of running AI algorithms beside the decision support algorithms to look for quantitative biases, and then to flag those. And then lastly, I think that there's an interesting emerging technology around synthetic data. And we know that AI, if it creates synthetic data, can create biased synthetic data, but it can also unbias that data in ways that may be useful. And again, this is a very formative field, but I do think that in addition to the human and policy issues that Jolene was talking about, there may be some tech issues that we can apply here as well.
Yeah, let me tie into that. I think what Bill is referring
Leo,
to.
and then we'll go to Cynthia.
Oh, sure. So I think what Bill is referring to is the latest discussions around generative adversarial networks, which is a way to generate synthetic data. And I've often been at work saying, can't we, we have some lab results that we don't have many of. Can we make some fake lab results to increase the precision of the algorithms? And when it comes to bias, the start of bias is actually, I'll talk about the start and the end of bias. So the start of bias is when you have a data set that is not representative of the data set actually evaluate on. So for example, if you train an algorithm to detect certain conditions in a population that is over 65 years old, like the Medicare population, and then you apply it to a population that's younger, the prevalence of different diseases, of course, in different age groups is different. So what we had to do was to kind of correct it with the logic in the end. And that's where these technologies that Bill alludes to will become really important. But we are biased as individuals. So it's also when you interpret the data. So I think that we have to think about all the way to who actually sees the data and what conclusions you draw from the data. So I don't think AI will fix bias, but I think we can have transparency around how the algorithms are created. And just let me make a final comment. I know that Jolene made a comment around who is using the data, what type of data. The data I'm talking about is the data that belongs to me, essentially my electronic healthcare record, my lab results, my claims, my doctor's notes, the things that the providers of my care already have about me. So that's the data I was referring to in the earlier discussion.
Thanks, Leo. Cynthia.
Yeah, thanks. I do want to actually exactly pick up on this question of interpretation and whether or not we can solve it with just being, better at maths. I wish that were the case. I fear it's not. For example, when I think back to the research that's been done around Project Maven for the US Department of Defense, which was designed to, in their terms, increase the precision and accuracy around situational awareness for drones in counterterrorism use. Sorry, I'm an IR professor. Their own statistics said that was 19% accurate. Okay, 19%. So I don't need more calculus than that to be able to, actually I have no calculus, but I don't need more maths to be able to read the page and say what the Department of Defense has actually told me. And there are a lot of good critiques of this out there. It's also, there's a politics here, and the politics gets underplayed by the desire for there not to be any politics in these things. And I find it myself. For example, I live in the United Kingdom. I live in England in the United Kingdom. During a global pandemic in which the number of cases in the UK is rising, where today's R rate was 1.1 to 1.4. And deaths are increasing, and people are, hospitals are beginning to fill up because of COVID-19. And what I would love to see in the UK is a functional track and trace system, test, track, and trace. This government promised us that and actually tested one on the Isle of Wight. And it ended up having to discontinue that whole project for what I would argue are largely political reasons. Firstly, it decided to have a national track and trace app rather than buy into the Google, Apple track and trace app. Why? Because the UK government wanted to store this data for, I don't know if it's 20 years, for 20 years. And Google and Apple, who are not always known to be the most, the best at, privacy issues, said, no, we're only storing it for 30 days. So and the UK government persisted and thought, oh, well, they'll let us use their infrastructure to make this app work anyway. And Google and Apple said, no, we're not. So the app was abandoned. So that's one kind of issue where, these judgments come into play. One last example, also sort of going between that kind of, picking up on a point that Bill was talking about in terms of, amalgamating data sets and being able to use data sets from all sorts of different parts of, you put it articulately, Bill, I don't know the terminology, but, using different data sets to solve particular problems. One of the things that the UK government announced yesterday, I believe, is that it's in a post-Brexit era, it is going to have an AI, a border tool, a UK border tool. And it's going to be, the contract has been given to Peter Thiel's company, Palantir. And what that border tool will, some critics are arguing, is it won't just be looking at who's crossing this border or that border, but maybe it's going to look at who used the healthcare system. So amalgamate these kinds of data sets so that all kinds of data actually now become border security check data. And that's a real concern. That's an ethical issue. And the other thing that's worrying for me is that the UK government has argued that what it's going to do now is it's going to change the law to make that legal. So what we have is a system where data tech needs can drive legality of government legislation. And I can understand technically why sometimes that needs to be, but what are the moral and ethical issues here? And shouldn't it be the other way around, where what we think of as legal protections for populations and individuals ought to drive then what is allowed to be collected and how it's allowed to be used and in what context?
Well, sort of building on that, I mean, we recognize the huge potential. We also recognize the huge challenges that requires sort of multi-sectoral coordination and collaboration to move AI forward. As I think we've seen and hopefully can agree, public health and especially global public health are often late adopters of new technologies. So in the face of these challenges, like we've all laid out, what are either some examples or things that you would all like to see around better coordination and collaboration, whether it be regulatory, policy level work, innovator support, people making investments in these innovators? Where are there ways for us to collaborate to move this space forward faster, to move past the hype and into practice?
I'll take a crack at that first. And I think it's people. It's not technology, it's not data, those are important, but I think investing in people. And one of the things that I fear about public health's ability to use these technologies effectively and safely and be informed consumers of these policies to avoid the issues that Cynthia and Jolene talked about is our workforce. And right now, we have a workforce that's aging, that has a difficult time attracting data scientists and informaticians and people who can really understand the science and the practicality and how to use them and how to avoid getting into trouble. Frankly, public health department at a state or local level or even a federal level can't pay enough, can't pay what IBM pays for newly minted folks coming out. And so I think that's a challenge, and I would suggest that there are 3 solutions. I think the first is, the good news is that there is a cohort of epidemiologists and people who translate science into practice, and thinking about mid-career training for that cohort, I think is very, very critical. the second is I would think about public-private partnerships, how all of our organizations can collaborate, particularly at the state and local level, to lend the private sector expertise to help government as well. And by that, I don't mean having the fox guard the hen house. I don't mean regulatory capture. I really mean true partnership. And then the third is a technical solution, and I think cloud-based computing can offer low-cost entry into these technologies. Again, provided that the people are sophisticated enough to use that well. And so I think that the cost of entry for public health on the technology side is decreasing.
Great. Anybody else want to build on that?
I personally think we have to make the patient a superhero. I think that in the context of telehealth, you know, a lot of the telehealth today is doesn't really take my information into consideration. If I call into a telehealth provider, they don't even have access to my data. So they may say, "Are you on medication?" And I said, "No, I'm not." And lo and behold, I may have been on the medication 3 years ago. There may be some lab results in there that indicate that I need to get looked at for some other thing. So I think that it all starts with the patient. It all starts with the individual. And I think that conversation gets lost. So there is technical solution. It's not, as Bill said, a technical problem. It's a people problem, but it starts with the patient. I think we ought to make the patient a superhero.
So a related sort of angle to that is if you are, if you have 10 minutes to talk with somebody on the Hill, so your local senator, congressman, congressperson, what are you telling them in terms of what they should be doing to create a space and move this forward more quickly?
Actually, I do that a fair amount as part of my job.
What do you tell them?
I talk about investing in a national data enterprise that has all of the appropriate safeguards around consent and privacy and security. But we see a lot of data blocking pursuant to somebody's comment. I think it might have been Jolene about the monetization of data. And so we're seeing the EHR companies think it's theirs. The healthcare companies think it's theirs. And everybody's trying to monetize that. So have the free flow of data with all of the privacy and security and ethical issues is huge. Investing in interoperability, so each system doesn't have its own walled garden, is a second one. And then third, invest in local and state public health, governmental public health infrastructure, because it's been chronically underfunded. And we see the challenges of contact tracing and the challenges of testing. And it all gets back to the fact that public health has been neglected resource-wise for generations.
Cynthia or Jolene, I'd love your perspectives on this.
Actually, I have one point to make. I think there needs to be more dialogues and discussion on the issues we talk about, and we need to bring in different stakeholders to talk about the policies and also the regulatory measures before we go full speed, move on into developing AI and using it for public health. So we need to really discuss around the three narratives, and we need to consider all three of them, not just the benefits or just the fear of risks, or just talking about the freedom of the companies and about making money and stuff. We need to bring all the voices and consider all three different narratives and reach a balanced and also responsible answer for our future generations and also for ourselves. Because at the end of the day, all the stakeholders that we talk about today, they are also users of public health, and they themselves are gonna, we need to be responsible of our own future and our own applications of the public health system. So that's my point.
Perhaps as a hook onto that, you know, I pretty much agree with what Jolene and William have said, and something to maybe like bring it back full circle. I think I opened the call with saying that I believe one of the key issues that we're facing, you know, on more of the public sector as well as in defense, is the issue of information overload as well. We are having these conversations, but because, as William said, you know, there are a lot of people who have not been invested in, so we have a resource drain, or we don't have the people ready to handle this information. The key result is people don't know how to interpret this wealth of information that's being aggregated and being brought in. And so from a more practical standpoint, what would be helpful is if we could either introduce a maybe like layer or like even a potentially like sect of jobs where basically there are people dedicated to applying their expertise and understanding technical information, but in a way that can bridge that to people who are also non-technical. I think these sort of unicorns are very essential, especially in this initial filtering process of converting, you know, large amounts of data into something that can be understood at a high level. And then the second point, David, that I think would be quite interesting, and this is now a little bit more leaning technical, is how do we actually standardize our approaches to robust AI? I know that some of us had discussed, Leo, you brought up generative adversarial networks, and a lot of, you know, just bad actors typically can use visual data and contort it by introducing some forms of noise or making it just, how do I phrase this? They can make data uninterpretable and throw off classification algorithms such as convolutional neural networks. And if I could speak to someone maybe on the technical policy, and something that would be quite important would be to explore the use and standardize perhaps the research and use of a method known as mixed integer programming. So there's actually applications of mixed integer programming, which is a subset of optimization techniques that can be used to basically check in an image. Like, let's just pretend you have an image of a cat, I'm a cat, and you manipulate each pixel. So mixed integer programming would actually evaluate each pixel and validate, did it go through like some form of manipulation? Was a bad actor involved in changing my root data before I classified it? And so that sort of intuition, that understanding, and maybe putting aside a pot of money and time and space for people to look at robustness early on as we enter the 20s, that could potentially pay off a lot in the next few decades.
Well, this has been a really great hour. I know personally I've learned a ton. If I can just sort of give my own kind of perspective on where we need to be investing together, I would agree with what Bill had said. Investing in people, where I come, the space where I work most closely, you know, most recently at USAID, but primarily focused on Africa. We need to be investing much more in that human capital, specifically in ministries of health, specifically around leadership and management ability to understand this space, but more importantly, make smart investment decisions on designing and implementing these programs. So I've learned a ton from all of you. I found that really interesting. And as we wrap up, I'd love to send it kind of around this virtual room for really short, what I would say Twitter-sized comments. And we'll go in the same order that's on my screen again. So we'll start with Leo down in his recording studio.
Thank you, David. So AI is all about predictions, making predictions that are accurate, making predictions that are contextual for the user, and making predictions that are unbiased if possible. And I think that that is the opportunity we have to leverage the technologies that are out there in the private sector to make predictions to help people get better and improve people's health.
Great. Let's go over to Jolene.
My conclusion is AI and public health should be guided by humans, designed for humans, and benefit humans. Human rights, zero discrimination, and zero stigmatization should drive AI forward.
Love that, Jolene. Cynthia.
I'm so unaccustomed to Twitter, Dave, that I actually wrote out my tweet. That
All
tells
right.
you how old I am.
I like this.
So it's probably, probably doesn't work as a tweet anyway, but I think I'm within 280 characters. And I would say something like this: optimistic accounts of AI and big data promote AI as the urgent, easy, and obvious solution to policy problems like public health. Be skeptical, demand evidence. Be diligent, research AI stories, not just AI tech. And be demanding, require ethics-led, not ethics-washed AI and big data proposals.
That's awesome. I love it. In fact, I just live tweeted that right now, Cynthia. Just kidding. I didn't. I'm not on Twitter. But Bill, let's go to you.
It's very intimidating to follow Cynthia and Jolene. Wow. AI is not a magic brain. It's just math. And like any other tool, it's the people and the systems that really determine how it's used.
Awesome. Thanks, Bill. And Sean, last but not least. So this better be good.
Yeah, I guess I would say, to build a hybrid framework around public-private partnerships for AI, we need to develop robust approaches that can address information overload and support decision-making.
Awesome. Well, thank you all so much for this hour and your perspectives and thoughts. I learned a ton, and I hope that the people tuning in will as well, and I'm sure they will. I also want to thank Marguerite and the whole team at Tech for HIV for pulling this all together. It's not easy to bring these all these perspectives together. So thank you, Marguerite and team. And just to mention, when we do post this online, we'll also put a resource page. So some of the reports and some of the work that the panelists have done can be easily accessed. So with that, again, I want to thank you all and hope you all have great rest of your days.
Thank you.
Thank you, Dave.
Your pleasure.
Yeah.
Thanks, Marguerite.
Thanks, everyone. Good meeting you all.
Yeah, lovely to meet you all. Thanks for the conversation.